Hello, I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. I wanted to take a few minutes here and highlight some new information as it relates to guidelines that were put together as a consortium of gastroenterologists, cardiologists, and hematologists coming together to answer some questions about what's the global risk for stopping anticoagulants or antiplatelet agents in patients at risk for GI bleeding or with active GI bleeding. And we're talking as gastroenterologists of what's the risk of continued GI bleeding, but the cardiologists come in and say, well, our drug-eluting stent is in jeopardy here if you stop these agents. I'm not going to go through these in full detail, but let me just give you a snapshot highlight and invite you to review the article and then discuss this further with your colleagues. Patients that present with GI bleeding, the recommendation is to do everything you can to continue in the patients defined at risk for stent occlusion, patients with coronary stents that are relatively young, within 12 months, and a drug-eluting stent. Basically, just continue these agents as best you can, and to evaluate in concert with a cardiologist whether or not these need to be stopped. If you stop these agents, it should be minimum time off these agents, 5 days, and then there's going to be a rapid push to get them back on their clopidogrel because the stent occlusion risk is considerable in those patients. So patients always should have this dialogue between gastroenterologists and cardiologists about the defined risk of bleeding or the downstream consequences of cardiovascular consequences. These guidelines also address some interesting perspectives as it relates to elective GI procedures. And basically, the bottom line is if you are undergoing an elective GI procedure of low risk, and that is with or without biopsy, that's fine for an endoscopy or colonoscopy. Basically, it says that you can still continue your antiplatelet agents and anticoagulants if you're a high-risk patient for a cardiovascular event. It's different than the way many of us have practiced, and I suspect it may be different than the way that you've dialogued with your patients. If you are a patient that is a high-risk patient, meaning that you've got a mitral valve lesion and a prosthesis, you're an atrial fibrillation patient with a mitral valve problem, the patients that have recent venous thromboembolism, you need to also be deemed at high risk, and those patients should have a reevaluation. Do you really need the endoscopic procedure now? If you need to stop the antiplatelet therapy in these patients, it should be done with a close consultation with a cardiologist. So as a gastroenterologist, I would never stop clopidogrel without talking to the cardiologist. Ideally, they would say in this guideline that we'd wait a year for repeating the procedure, doing the procedure. Certainly 6 months is the minimum threshold recommended now, and if you have a bare stent, a minimum of 1 month. Rapid reinstitution of the antiplatelet therapy is warranted at that point, or anticoagulation. And if you have a patient on aspirin and clopidogrel, the recommendation now in concert with the cardiologist is stop the clopidogrel, but do not stop the aspirin, and the gastroenterologists agree with that. Patients can be done safely, even for therapeutic intervention with patients on aspirin. So the bottom line is review these new guidelines. I think they're going to set some new standards as it relates to an understanding of the gastroenterologist dealing with cardiologists and hematologists and saying, there are more issues at hand. It's kind of the blind man and the elephant looking at one side and saying my risk versus your risk. And we need to come together a little better and more formidably to create the best patient outcome. Hopefully I've tweaked your interest, and I'll engage you to discuss this further and hit that option in your webpage here and discuss this with your colleagues. Look forward to further dialogue with you. I'm Dr. David Johnson. Thanks very much for listening.